The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Hi, I'm hoping you can hear me well. So I'm Nashid, I'm the clinical data specialist for the eUROGEN, and it's a great pleasure to welcome you to another eUROGEN webinar. So for those of you who don't know, the eUROGEN is one of the 24 European reference networks which deals with the rare and complex urogenital diseases and conditions. And one of our main objectives within this reference network is to act as a focal point for medical training. And we aim to increase the capacity of healthcare professionals and patients to recognize and manage cases of these rare and complex urogenital conditions. So this is the aim of these webinar series. And in today's webinar, we will cover one of the rare cancers that is affecting the male urogenital tract. So we will be talking about penile cancer, and more specifically, we will focus on its surgical management and the problems that may affect patients in the long term after the surgery. So today, our expert is Mr. Ben Ayres from St. George's Hospital in London, and he will be talking about late effects of penile cancer and lymphedema. So during the webinar, please feel free to unmute yourselves at any time, because we are not tons of we don't have a lot of attendees. We can look for a more interactive webinar. So feel free to unmute yourself and interrupt the presentation at any time during the talk. So it's over to you, Ben, now, please. Thank you.
Thank you very much. So welcome everybody. What I'm hoping to do over the next half an hour, 45 minutes is talk about how we can try and reduce lymphedema in penile cancer surgery, but also how we can manage it. As we just said, please feel free to ask questions at any point through the presentation. You can do this either by unmuting yourself and asking out loud, or you can use the chat and question facility on this webinar, and you can type your question if you wish. At the very end, there will also be chance for questions. So inguinal lymph node positivity, we know, is the strongest prognostic indicator for cancer-specific survival in penile cancer. So if lymph nodes are positive, we know that the outcome is poorer than if lymph nodes are negative. On top of this, if there are lots of nodes, or if there is extracapsular spread on the nodes, this too gives a poorer outcome. Therefore, inguinal lymph node surgery is extremely important for diagnosis, for staging this disease accurately, for understanding whether the lymph nodes are involved or not, but also for treatment, for treatment to remove the lymph nodes. And we know from data and large national databases that patients that undergo inguinal lymph node dissection have better survival than those that don't. However, unfortunately, this surgery can result in significant genital and lower limb lymphedema, and this can have a significant impact on quality of life, and I will show you some data on that later on in this talk. So what I would like to cover within this talk, as I've said, is I'd like to talk about how we can maybe modify our surgical approaches to inguinal lymph node surgery to reduce the risk of lymphedema. But I acknowledge that patients, despite this, will still get lymphedema, and therefore I'm also going to talk about ways that we can try and manage lymphedema. Let's go back to what the roles of the lymphatic system are. The lymphatic system is involved in protein and fluid hemostasis. It's involved in cellular drainage from the tissues, and it's also involved in immune surveillance. So it has an extremely important function in the body. And if we have lymphatic failure, then we get lymphedema, which is swelling of the tissues. due to the collection of lymph in the extremities or in those tissues. If the lymphedema persists, then you start to get skin changes, elephantiasis skin changes. So you start to get thickening and hyperkeratosis of the skin. You'll then start to get little lymph blisters forming on the skin, and lymph blisters can then leak, and they leak out lymph. This is called lymphorrhea, and this can significantly impact on patients' quality of life, particularly in penile cancer. If it's genital lymph blisters, it can lead to a lot of discharge and leakage into the underwear, almost as bad as being incontinent. You can also then get these lymph blisters forming into papillomata. Infection is really bad in patients with lymphedema. So patients with lymphedema are at increased risk of infection because of the lymphatic failure. But unfortunately, once you get an infection, it damages the residual lymph drainage route. So you get this vicious cycle. So again, one of the key elements of trying to manage patients with lymphedema is to try and reduce infection. So first of all, how can we reduce the risk of lymphedema in patients undergoing penile cancer surgery? Well, a lot of our patients present with no palpable nodes in the groin. So clinically, they are staged as N0. They have impalpable nodes. In these patients, do we need to do a full lymph node dissection? So studies have looked at whether we can just watch these patients. And a study that I've presented there at the top of this slide, looking at just an observation versus sentinel node biopsy, dynamic sentinel node biopsy, showed that actually if you just observe patients, they do much poorer. They had a 35% 3-year survival compared to 84% 3-year survival if they underwent sentinel node studies. So observing these patients is not a good idea. How about using imaging? Can we not image the groins instead of operating on them? We're using data on an ultrasound scans of 400 nodal basins. 20 tumors were missed. This gave ultrasound a sensitivity of 52%, which is not good enough to replace surgery. We also know that the resolution of CT and MRI scans is only around 8 millimeters, so again is not going to pick up micrometastatic disease. And at this point in time, PET CT scan cannot pick up micrometastatic disease either. So we cannot rely on imaging studies. We could do risk adapted nomograms. We know that if a patient has a low grade, very superficial tumor, a G1TA or G1T1, they have a very low risk of lymph node metastasis, and so you may choose to watch or observe those patients. However, very few patients are G1T1, more are either G2T1 or G3T1 or higher. And as you can see, the risk increases there. With G2T1, it's 12%, G3T1, it's 15 to 35% risk of micrometastatic spread in patients who do not have palpable nodes. If we were to perform inguinal node dissections just in those with that high risk group, G3T1 or above, we will overtreat a huge number of patients. This study looked at data from my unit, St. George's Hospital, and also the Netherlands Cancer Institute in Amsterdam. They looked at 245 high-risk patients and found that 23% of them had microscopic metastasis to their inguinal lymph nodes. They found that grade and lymphovascular invasion were significant predictive factors for developing micrometastatic disease. But despite all this, they said that based on this data, 77% of high-risk patients with no palpable nodes would have undergone bilateral inguinal lymphadenectomy, and lymph nodes would have been negative. So a huge amount of overtreatment if we are to do inguinal lymph node dissections in these patients. However, as I said at the very start, it is very important that we do do lymph node dissections, that we do find out whether lymph nodes are involved with cancer, because that has a significant impact on the patient's survival. Therefore, we could consider using sentinel lymph node sampling. The sentinel lymph node concept is that the spread goes in a stepwise and predictable fashion along the lymphatics. So the first lymph node in the chain acts like a filter, and if that node is clear, then the rest of the lymph node basin should be clear. There is one exception to this rule, and that if the first node is very full of tumour, then the drainage may go direct to the second node. When you do the sentinel node study, the radionucleotide dye that we rely on to show us which node to surgically remove as a sentinel node may actually go onto the second lymph node and not the first, and therefore you may remove the second lymph node, which may be clear, and miss the first lymph node that isn't clear if it's full of tumour. So you'll find that most of us that do sentinel lymph node sampling also add an ultrasound scan into our protocol, because that will pick up the first node being considerably full of tumour, and so hopefully prevent this from happening. This is our data from St George's Hospital in London, published in 2013. This was on our first 264 patients having inguinal sentinel lymph node sampling in penile cancer, and there was a minimum follow-up of 21 months. In total, 500 groins were operated on with a complication rate of 7.6%. This complication really were infections and occasionally some lymphocele, so that's collection of lymph in the groin requiring drainage, and some temporary lymphedema. None of these cases had permanent lymphedema, although now that we've done 1,500 inguinal sentinel node studies, we have had a couple of patients who have unfortunately had permanent lymphedema as a result of their sentinel node studies. With the first 500 inguinal basins, we found that 14.6% of the inguinal basins were positive, which corresponds to 22.3% of the patients having micrometastatic disease. We had 4 false negative studies within 18 months, and we would have had 2 further false negative studies if it had not been for that ultrasound scan that I mentioned on the previous slide. So in total, we had 94% sensitivity per patient. Now, similar results to ours have been reported in our other large European penile cancer centres, such as Amsterdam and the Christie in Manchester and University College Hospital in London. And all of the studies have shown a 5 to 7% false negative rate. However, other hospitals have reported higher false negative rates, and therefore have not been sold on the concept of inguinal sentinel lymph node sampling because of their concern about higher false negative rates. And they also comment that to do a sentinel node study, you do the study first, you then wait for the pathology result before doing a completion groin dissection if the node is positive, and therefore the patient has to come back for a second operation. And in some parts of the world, poor patient compliance means that a 2-step approach is not appropriate, and it is better to do the operation in one go. So if you don't wish to proceed with sentinel lymph node sampling to try and reduce the risk of lymphedema, what can you do? Well, you could do a modified inguinal lymph node dissection, or you could do a minimally invasive approach. So a modified inguinal lymph node dissection means removing slightly less lymphatic tissue. You try and preserve the great saphenous vein to try and help with drainage, and you concentrate your dissection medial to the femoral artery and try and preserve the lymphatics lateral to the femoral artery. Suprainguinal incision is often associated with reduced wound complications, in particular reduced wound necrosis. You could also have a minimally invasive approach. This paper here looked at consecutive open surgery followed by video endoscopic inguinal lymph node dissection. The follow-up for the open lymph node surgery was greater than the video endoscopic because that was introduced as a second procedure. What they found is that doing the procedure minimally invasively, yielded similar numbers of lymph nodes as the open procedure and a similar number of positive nodes. So it didn't seem to be oncologically inferior in terms of missing or not picking up as many lymph nodes. The wound complication rate was a lot lower with video endoscopic inguinal lymph node dissection at 6% compared to 68% with open. Lymphocele rates were similar, 20% in open versus 7% in the minimally invasive approach. But interestingly, the lymphedema rate was significantly lower in the video endoscopic lymph node dissection at 3% compared to 37%. So perhaps we should be doing minimally invasive surgery if we can't do dynamic sentinel lymph node sampling to try and reduce the risk of lymphedema. The suggestions as to why lymphedema rates are much lower in minimally invasive surgery are that perhaps there's less wound complication, less wound infection, so you don't get that vicious cycle of wound infection causing worsening of the lymphedema. And also you probably do preserve some of the skin lymphatics. However, you are still removing quite a significant amount of the lymphatic drainage, so it is surprising that the rates are so low. Further studies clearly are needed to let us know whether this is true and something we should follow up on. And more people are now doing minimally invasive surgery, including robotics for this. After surgery, what can you do to try and prevent lymphedema? You can get full-length compression stockings on your patient. Look after their skin, good skincare, and I'm going to talk about that in a minute. Get them mobilizing early, because early mobilization will use the natural pump within the body to pump the lymph around. Try and prevent wound infection using antibiotics if required. Also prevent lymphoceles. It's been shown that if you have a high rate of lymphoceles, you're more likely to get lymphedema. So using suction drains potentially for some period of time after the surgery is important. And also some studies have suggested putting a vacuum type dressing onto the closed wound can reduce lymphedema. Now, clearly all these strategies are important if you can't do the minimally invasive or sentinel node approach, which you can't do if the patient has large lymph nodes. Large lymph nodes are not suitable for either of those approaches, and if you have palpable lymph nodes, then that's not suitable for sentinel node sampling either. However, despite all these strategies, some patients will develop significant lymphedema following inguinal lymph node surgery. And this is especially true if you're dealing with larger inguinal nodes and possibly also removing pelvic nodes if they're present at presentation. So if lymphedema does occur, how can we manage this? And it can either be genital and or lower limb lymphedema. Before I come on to how we can manage it, this is some of our data from St. George's Hospital using a validated questionnaire just to show how much lymphedema can impact quality of life. So we asked all men over a 3-month period coming to the clinic who had had either inguinal and or inguinal and pelvic lymph node surgery to fill in a validated questionnaire. And this table shows the results of the domains of that quality of life questionnaire, with the percentages for those that answered the question as scoring it as poor or very poor. So it's a 4-point scale, and these are the lower 2 points on that 4-point scale. So as you can see, 22% of men who had inguinal node surgery claimed that their functional domain was poor as a result of the surgery and the impact of lymphedema on them. This goes up to 50% if they had pelvic node surgery as well. Fewer are concerned about the appearance. Patients seem to get more symptoms of the lymphedema if they have both pelvic and inguinal lymph node surgery. And as you can see, mood was much poorer in those that have had inguinal and pelvic lymph node surgery. And this possibly represents the fact that they've undergone more treatment. They will have had more adjuvant oncological treatment as well. And therefore their prognosis is also more uncertain. But as you can see, their overall quality of life is scored very highly in both groups. So as I said, how can we manage patients if they do get lymphedema? Well, the aim is to get the most out of the remaining lymph drainage capacity that you have. And what you really want to try and do is reroute the lymphedema and try and prevent it returning. And this is done mainly by lots of conservative measures, including massage, compression, exercise, and elevating the limbs when resting. Prevention of infection, as I've already said on a couple of occasions, is extremely important too, because if you get infection, that damages the remaining lymph drainage capacity that you have, and therefore leads to more lymphedema. So we need to practice good skin care and possibly give our patients antibiotics as well. This is very much a multidisciplinary approach, and at St George's Hospital we work extremely closely with our lymphedema team, and I must thank them for their help in putting these slides together. So the conservative therapies that you may hear mentioned might be MLD, which stands for manual lymphatic drainage. This is specialized massage done by a specialist therapist. Or MLLB, which is multi-layer lymphedema bandaging. There are also garments that can be used to cause compression instead of the bandaging. And occasionally we do debulking surgery, and there is some mention of lymphatico-venous anastomosis in the literature as well. But the predominant approach here is conservative therapy, not surgery. So skin care. First of all, we can only use these creams and gels if the skin is intact and there's no hyperkeratosis, but the best ones that we would recommend to use are double base emollient or gel wash or Adex gel. Other creams and sort of paraffin creams can often cause irritation and itchiness to the skin, and then if the patient itches the area, they can break the skin, they can get infection, they can worsen their lymphedema. Multi-layer lymphedema bandaging can either be done to the lower limbs or genitals. When it's done to the genitals, it's often best taught to the patient to do it, because often the dressing can work well and cause a reduction in the lymphedema, which means then that the bandages start to fall off and they may need reapplying several times a day. So it is something that we ought to try and teach the patients. And I've got some slides coming up just to give you an idea of how you might do that bandaging. So here's a picture of lots of different types of bandaging products one might use. Here's a picture of one of our therapists having had their leg bandaged. You can see the delicate bandaging around the toes there as well, so you're getting full compression of all parts of the tissue. And here is how you might go about genital bandaging. So start off by bandaging around the penis, and then cut out of some of the bandages a pouch that you can fit the penis through, then put some padding around that, and then some stronger bandages. However, you can also get compression garments rather than doing the bandaging. Sometimes these may be more easier for the patient to put on, or they may find that they're more comfortable than the bandaging. So you can get various types of scrotal supports, but the best ones really are compression shorts that have a pouch at the front that lifts the genitals away from the body, because if you just compress the genitals against the body, it's not going to work. You need to lift them away and then compress them to get rid of the lymphedema. If you can't get compression shorts, then you could try cycling shorts, like the Lycra bicycle shorts that you can buy from sports shops. These often are reasonably effective, but specialist lymphedema compression shorts are better. You can get full length compression stockings for the lower limb. These need special measurement to get them fitting properly. And if the patient struggles with them, then there are special Velcro wraps that you can build up along the leg, wrapping the Velcro tighter and tighter to try and help with the leg swelling. Massaging, as I said, is an important part of the treatment, and it aims to reroute the lymphedema. Now, there are videos of how you might do this on the internet, but really the best way to learn is to see a lymphedema specialist MLD therapist to do the treatment. The videos do not give you the information that you need. So this is best taught in the outpatient clinic by a specialist MLD therapist. And we use it in our practice commonly for stubborn swelling at the mons area just above the penis, or lower abdominal wall swelling, or if there's thickening and lymphedema of the penile shaft after surgery. Now, exercise and healthy eating is extremely important. Fat and lymph use the same pathways. So if the patient has a high body mass index or has a large abdominal fatty apron, this is going to impact on their lymphatic drainage. So losing weight in these patients is important. Therefore, aerobic exercise has a big role in helping with this weight loss, as does healthy eating. But also aerobic exercise will help the natural muscle pumps try and pump the lymphedema around. And by encouraging deep breathing, they'll also change the pressure inside the chest to help with the lymphatic drainage back to the heart. It's important also that patients do stretching and become more flexible if the limbs have got a lot of lymphedema, and do strength training as well. Now, if the patient gets an infection or cellulitis as a result of their lymphedema, then the treatment of choice will be often amoxicillin or co-amoxiclav with some gentamicin added in if the patient is in hospital. And often these patients do need hospital admission because cellulitis gets bad very quickly. If they don't respond to this treatment or have a penicillin allergy, then we would recommend clindamycin. If a patient has 2 or more episodes of cellulitis in a year, then we start them on prophylaxis, because as I said, this is a really vicious cycle and we want to try and prevent these patients getting recurrent infections, because it just worsens their remaining lymph channels and therefore worsens their lymphedema. So if the patient needs prophylaxis, we'll prescribe them penicillin V. If they're allergic to penicillin, then we'll give them erythromycin. And if either of these are not effective, we'll then move on to clindamycin. So as I said, there may be a role for surgery, although we use this rather sparingly in these patients. Debulking surgery, particularly for genital lymphedema, seems to be effective. This will involve excising much of the scrotal skin and lymphedema. Often the perineal skin is preserved, and there's enough preserved perineal skin to bring it back together with sutures in the midline. So rarely do you need to use skin grafts to the scrotum, although sometimes you might need to as part of the reconstruction. But as part of taking the scrotum off, often the penile skin is lymphadematous as well, and that comes off sort of en bloc with the scrotal skin, and therefore you would need to put a skin graft on the penis. Some people talk about limb liposuction followed by compression bandaging. The case series on this are small and there's no long-term follow-up, but the results seem to be effective in these small case series. And then other people talk about lymphatico-venous anastomosis, and really there is limited evidence for the benefit of this in penile cancer. So to summarize, my take-home messages are that inguinal node surgery is extremely important in penile cancer because it improves survival, and therefore it is something that we must talk about with our patients and really encourage our patients to undergo because of the benefits of it. Clearly, lymphedema is one of the side effects and consequences of this surgery, and so we need to try and prevent our patients developing lymphedema by our surgical approach if possible. So trying to do dynamic sentinel lymph node sampling or minimally invasive or modified inguinal lymph node dissections where possible. But if patients have palpable lymph nodes or large lymph nodes, then they're often going to need open inguinal lymph node dissection, and some of these will unfortunately develop lymphedema. If the patients do develop lymphedema, then you need to have a multidisciplinary team approach, and your lymphedema team will be very important to this. The majority of the treatment is conservative and involves good skin care, compression, massage, elevation, and exercise. debulking and other surgeries may have a role. As I said earlier in this talk, I'd like to acknowledge Dr. Christiana Gordon and Mark Fearson, who are our lymphedema team, for their help in producing this talk. I'd also like to thank my colleague, Professor Nick Watkin, for all his support, our urology cancer nurse specialists and registrars past and present, and my PA, Leslie. I'd now like to open the floor for any questions. Thank you.
Did you forward the question?
Yeah, thanks, Ben. I'm just saying, one question has come through on the chat. I don't know if you can see it on your, see the questions now.
Let's have a look. Questions, yeah.
So there's some comments, and then there's a question from Ahmad Khalifa as well.
So the question here I've got is inguinal lymph node or only deep? So I presume this is referring to the
whole question, do you remove superficial and deep inguinal?
Oh, I can't see that.
Okay, you might need to expand it possibly if you click on the little box.
Yeah, try and expand the box. How can I expand the box?
There's a little arrow pointing kind of up to the right. You click on that.
No. Okay, yeah. So do you remove superficial and deep inguinal lymph node dissection or only deep? I must admit, the vast majority of the times I do inguinal lymph node surgery, it's because of positive nodes. So I will remove deep and superficial nodes in those situations. We use dynamic sentinel lymph node sampling in all our clinically node negative patients, unless they are G1, T1, in which case they're very low risk and we'll observe them. So because we use sentinel lymph node sampling for all our other clinically node negative patients, when I then come to do a full groin dissection, it is because there are positive nodes there, or have been positive micrometastatic nodes at sentinel node biopsy. So I will remove superficial and deep nodes.
There's a couple from Oscar as well that's come through, so if you want to see that.
Okay, let's scroll up. No, I can't.
Sorry, I need to sign to you. 1 second, sorry. Hopefully you see them now.
Here we go. What is your, okay, so this is another question. What is your post-operative protocol to minimize lymphocyl after inguinal lymphadenectomy? How long drain, vacuum devices, antibiotics? So we have our patients in stockings as early as we can. We like to leave the drain for as long as it's necessary. Actually, we leave the drain until we're getting 30 to 50 mils of drainage in 24 hours, and we leave it for at least 2 weeks minimum. Even if that is achieved within the 2 weeks, we leave it for 2 weeks minimum. But we really like to minimize the risk of lymph. So as I said in the talk, there is some good evidence out there, not necessarily in penile cancer, but in other groin dissections for melanoma and gynecological cancers, that if patients develop lymphocyls post-operatively, they have a much higher rate of chronic lymphedema. So we want to try and reduce that risk of lymphocyls, so we leave our drains until it's 30 to 50 mils in 24 hours. But I know that there's a lot of variety in this across Europe and the rest of the world, based on a survey we ran last year. In terms of vacuum devices, our drains are suction drains, but additional vacuum devices to put negative pressure onto the wound, I haven't tried. Again, there is some literature not associated with penile cancer, but with other groin surgery for melanoma and gynae cancer, that suggests that putting vacuum devices may reduce lymphedema. So that's something interesting in the literature and something that we possibly should explore further. In terms of antibiotics, I give my patients 2 weeks of of oral antibiotics after their groin dissections, 2 weeks of augmentin. I do wonder whether, given the vicious cycle that infection can cause with lymphedema, I do wonder whether they should maybe go on a low-dose antibiotic after that until we're happy that the drain is out and the skin is all healed up nicely. But my practice at this stage is 2 weeks of oral antibiotics when they go home. But again, I know that varies from institution to institution.
So a couple more after that as well, Ben, I think, if you can see them.
Yeah. So definition of deep nodes. I mean, when I do a clearance, I'll take out all the nodes in the medial compartment of the thigh, all around adductor, the adductor muscle, and I'll take all the lymph nodes around the femoral vessels. So I'll skeletalize the femoral vessels and go down beyond Hunter's Canal, taking the lymph nodes down there. So those are the areas that I dissect. Okay, what is your recommendation? If one side is positive, do you look after the other side, e.g. left? So I presume this question is if one groin has a positive node and the other groin has a negative clinically, what do I do? I would do a groin dissection on the positive side, and on the side where there is not a palpable node, where it's impalpable, I would do a sentinel lymph node study. Clearly, if that sentinel lymph node study is positive, I'll then go on and do a completion groin dissection, but I'll treat each groin in its own on its own merits. So if there's a palpable node, I'll treat that with a full groin dissection. If there's a no palpable nodes, I'll do a sentinel node study. We have looked at our data at St George's. We know that if the patient has a positive groin on one side, then the chance of the other groin being positive is about 40%. So that's double the risk that we would normally find with sentinel nodes. Normally with sentinel nodes, in a groin with no palpable nodes, with sentinel node study, you'd find 20% chance of finding microscopic disease. We know that if one groin is positive, then actually that chance goes up from 20% to 40%. However, I'd still argue that sentinel lymph node sampling is a reasonable approach there, because you're doing it to reduce the morbidity, and 60% of your patients will not have a positive node, and therefore you'll be, benefiting those patients. So we would treat each groin on its own merits. Is there another question?
There's the one from Ari, yes.
Do you think the type of device you use makes a difference in lymphocyte rate? For example, if you use monopolar ties, harmonic, etc. So again, we did a survey last year, and we know that people approach their groins differently. Some use harmonic scalpel, some use ties, some use Liga clips, some use diathermy. What the literature would suggest is that rates of lymphedema are potentially higher if you use diathermy or if you use a harmonic scalpel. Again, not necessarily in penile cancer. This may be data from melanoma groin surgery and gynae groin node surgery, but it suggests that diathermy does not work. And actually, we found that with our sentinel nodes at St George's. We moved from clips to diathermy and then back to clips again, and we audited each of the three groups and found the complication rate, particularly for lymphocyte, went up significantly in the middle group. So diathermy, we know, does not work in our experience. And as I say, there's data that harmonic scalpel does not reduce the risk of lymphedema, in fact increases it. So I think ties and clips are important. Some people talk about injecting patent blue or another dye into the lymphatic channels after you finish the groin dissection to try and pick up any areas of lymph leak and try and tie or clip off those areas as well, and have shown reduced lymphocils as a result of doing that. Other people have tried tissue sealants into the groin to try and help reduce the risk of lymphedema or lymphocil forming. And all the studies that have used tissue sealants and meta-analyses of those studies have found no benefit. Okay, that's I think the last question. Is it, Darren? Are there any more questions to come through?
No, that's fine. That's everything. So
we'll give,
I guess
we'll give
now. Or,
if nobody has any more questions to type, I mean, if you do, please start typing now, and we'll see it come up. But if nobody has any other questions to ask, thank you very much for attending this evening. I hope the talk has been useful, and I hope the question and answer session has been useful too. So thank you for your attendance tonight.
Yeah, thank you, Ben. I just want to add that we've recorded this as well, so we'll send a direct link to everyone, all the registrants, in the next day or so as well, in case you want to watch it back or check particular parts of it. So, and thank you for attending. Okay, I'm going to close.
Thank you and bye-bye.
Cheers.